Facelifting is a commonly requested procedure in my office. I know many of you may have gone home and pulled on your face, or you looked at an old picture and you said, I'm looking a little old in that group photo. But now you want to know exactly what is the process in terms of the consultation, what happens during surgery, what happens after surgery, what kind of risks, what kind of benefits can I expect from this procedure. I'm going to go through each step with you today, and in the end you're going to come out much more educated about what a facelift does and how it's done and what to expect. The first step of any interactive process, of course, is the consultation. It's a period of time when you get to know me and I get to know you. I get to understand what is that exactly bothering you. So you're going to come into my office and presumably you're going to bring old photographs with you, and then I'm going to compare the old photographs to the current ones, and we can see what kind of changes may have occurred over the years. Then we're going to discuss what is exactly motivating you to consider having a facelift. Is it you have loss of self-esteem, you just look older, you want to look more refreshed, you want to look natural, you want to look joyful, you want to look like you have more energy? Is it something at work that's promoting you to consider having a facelift? Maybe the young guys, the young women in the team are looking upon you as an old person and you don't want to feel like you're the old person in the room. I don't know, but there are many reasons and many motivations why people have facelifts. Now, some motivations are realistic and some are not. So what does that mean? Some people say, well, I want to look 30 and I'm 60, or I want to look 20 and I'm 40. Well, that may be what you want, but it may not be what we can achieve, okay? Because things have changed over the last decades to make you look the way you look. We together will decide what makes a logical sense in terms of what kinds of steps we have to take to achieve the best results possible. I didn't say perfection, by the way. I said improvement. Improvement is a key goal for any surgery, especially cosmetic surgery. So we always have to keep in mind that we're not looking for perfection, we're looking for improvement. Significant improvement, but not perfection, because nobody's perfect to begin with. We're trying to make it as beautiful or as handsome as you were a decade ago, but not when you were 20 years old. So the objective, of course, is to look younger and to have well-concealed incisions so that you don't have what we call stigmata of facelifts. So in other words, we don't want to have incisions around your face. It's a dead giveaway that you had a facelift. I try to conceal all the incisions and camouflage them to the best of my ability so nobody should really point you out in the crowd that you had a facelift. I don't want you to look too pulled. I don't want you to look too tight. I want you to look natural. I want you to look refreshed, but not artificial or overblown or overbloated. And too many results that I see either coming into my office or on the internet look overinflated and unnatural and actually distorted. So that's not the objective. The objective is to look natural, better, improved, and not necessarily perfect, but just a more refreshed look, and that's what we want to achieve. So after the introductions that we have together in terms of meeting each other and looking at old photographs, I then start analyzing your face. And I look for symmetry of the face. I look for asymmetries of the face. Maybe one eyebrow is too low, maybe one is high relative to the other side. Maybe there's a facial nerve weakness on your face that you've always had. I need to know that. I need to make you aware of those things prior to the procedure, because obviously we sometimes can adjust the surgery to make things look more symmetric, or sometimes you have to know about them because we don't want you to think that they were induced after surgery when you actually had them preceding surgery. I also look for other aspects of your face, including the skin texture, where things are sagging, how much fat is located on your neck, under your eyes, is the brow drooping, where's your hairline relative to your eyebrow, because I have to know the distance between the brow and the hairline. All those things can come into play in terms of deciding what the ideal surgical approach is for each one of those components. Now, when we look at the face, I look at it in its totality. I look at the shape of the face, and I want to know in my own mind how things are going to look after surgery. So I try to project ahead of time what the patient is going to look like. I want them to retain their natural appearance. I don't want them to look different. I want them to look a better version of themselves or a younger version of themselves. So all these things are constantly floating through my mind in terms of my analysis. I have to dig deeper and find out, is there any other restrictions that may be imposed by their structural face itself. I spend a lot of time analyzing the facial shape of a patient, and there are many variations in shape that we all have. There are people with long faces and narrow faces like mine. There are people who have perfectly round faces. There are people who have squared off faces, and there are people who have what's called diamond-shaped faces, which are where the forehead is narrower than the bottom portion of their face. First of all, let's establish there are beautiful faces in every category. It's not one category fits all, obviously. There's so many variations and so many beautiful people. My objective is to really just to restore the kind of shape that they had when they were in more youthful age, and that means by lifting the tissues that have sagged downward, the jowls, the neck becomes slack, there may be accumulations of fat under the neck, the fat may be atrophied in the midface, the brows may have descended, the eyelids may be puffy. All those things may have occurred in a natural aging process, sometimes younger, sometimes older. Some people retain more youthful features for a very long period of time, especially if they haven't smoked and gone in the sun and done all those things or drank heavily. But be it as it may, the objective is to restore the structural components back to where they started, if at all possible. Now, recognize that when you have a facelift and you're 30 years old, or say you're mid-30s, and compared to someone who's 60, obviously you're going to have a much more dramatic improvement that's going to be longer lasting because you haven't lost the natural elasticity of your skin, and you haven't accumulated a lot of fat in weird places, under the neck and deep into below the muscle layer of the neck. The salivary glands may have not popped out. There's a lot of issues that may have occurred with age, and we try to address each one of these individual problems, and we take apart the puzzle and try to put the puzzle back together again. When I analyze a face, I actually divide the face into 4 parts: the top, the middle, the lower face, and the neck. When I start looking, for instance, at the brow region, I want to see, is there symmetry between the brows? Is one brow low compared to the other side? What is the distance between the brow and the start of the hairline? Because that can change my surgical approach in terms of preserving the distance between the brow hair and the hairline, because operating behind the hairline may recess the hairline posteriorly, and that may not be a desirable result. Also, if the muscles are big and thick, I may change my approach and actually do what's called an endoscopic approach to address the thick muscles along the brow itself. In addition, I'm looking for frown lines between the brow itself. So these vertical 11 lines are deep. I may have to take out some of the muscle to weaken some of that muscle to smooth out some of those deep lines. Going down a little further to the eyelid, well, the eyelid position is also impacted by a descending brow. So the brow may be pushing down on the upper lid, causing it to appear like there's a lot of extra skin, when in fact the brow position, if elevated, takes away a lot of that extra skin. So the brow and the eyelid are in a dynamic relationship in a sense. So we need to know what's going on with the brow first. Then we go down to the eyelid itself and we see, where's the bulging fat on the eyelid? Is it in the inner corner? Is it the outer corner? Is there lacrimal glands that are descending in the lateral portion of the eyelid? Is there a lot of laxity of the upper eyelid skin? All those things are taken into account. And then descending further down on the lower eyelid. Is the lower eyelid, are there bulges of fat on the lower eyelid? Is the skin crepey? Is there deep lines? Is there sun damage? Is there a loss of laxicity of the canthus, which suspends the eyelids? I need to be aware of that, because we don't want to induce a droopy lower lid when I remove any skin or fat on the lower eyelid. Sometimes the fat has to be grafted to the lower eyelid when there's hollowing of the lower eyelid, and we sometimes take fat from the belly and spin it down in a centrifuge and then inject some of the fat in the face. So there's a smooth contour from the lower lid to the midface. The midface itself may have lost a lot of fat. It's very common for people to have fat loss in the midface region as they age, and I have some of that myself. So in those patients, I consider doing some fat grafting on the lower lid to blend the mid-face to the lower eyelid, so it's a continuity between the lower eyelashes and the mid-face. And then descending a little further down, not only are the cheeks possibly a little flat, and they may need to be augmented with some fat grafting, but the lip itself lengthens with time, and you can get a greater distance from the bottom of your nose to the vermilion border, and some people want to shorten that to give the appearance of a fuller lip, so that's called a lip lift. Sometimes people just want augmentation of the lip with injections of fillers, and that's also an option. So all these things are constantly going through my mind saying, well, what can I offer the patient to get the very best results? And as we further go down in the lower portion of the face, obviously the jowls are a very key component, along with definition of the jawline, because all that can get blunted with time as everything starts to descend, and there's sagging of the tissues, and there's loss of definition, and that also changes the shape of the overall contour of the jawline. So instead of it being what is called heart-shaped or contoured along the jawline, now you have more of a squared-off contour as we age. And then, of course, the neck itself becomes lax. The skin, this is not just skin, this is muscle. There's a lot of muscle down here that becomes lax with age. There's loss of attachments in the center, and there's deep fat, which also bulges forward and causes what's called a submental accumulation of fat. So all these things have to be taken into account prior to even suggesting a surgical plan. So how do my patients prepare for surgery? Well, they have to first get a medical clearance. They need a cardiogram, and sometimes they need a chest x-ray depending on their medical history. I certainly want them off any blood thinners like aspirin, fish oil, vitamin E, Advil, Motrin, and so forth. And also, it's very important not to be on these weight-lowering drugs like Ozempic or Mounjaro prior to the surgery. I'm talking about a few weeks to a month prior to the surgery. It should be discontinued because sometimes the amount of fluid that is retained in the stomach, because the gastrointestinal tract is slowed down by these drugs, can cause an aspiration. So we are very conscious of patients now being on these weight-lowering drugs prior to a prolonged procedures. And these procedures are long. They can be 4 or 5 hours in length. We want to take every precaution we need to keep you safe. So in terms of the techniques that are involved in terms of facelifting, of course, is a general term because there are many, many techniques. And you can check out my other videos on the subject and my podcast on facelifting, because I go into great detail with other surgeons about their favorite approach to facelifting. Yes, there is something called a smastectomy, which is taking the smas, which is this fascial layer under the skin, and taking a piece of that and tightening it up. Then there's the deep plane facelifts, and there's extended facelifts, and then there's ponytail facelifts, and there's many, many different approaches. In everybody's hands, you can get some great results. Sometimes they're great results, sometimes they're not great results, and I've seen patients have deep plane facelifts where they got terrible results, and I've seen smastectomies where they're got great results. So there isn't only one way to do this procedure and end up with great results. So common to all these procedures generally is a vertical elevation of the mid-face area this way. There is a diagonal elevation of the neck in this direction, supporting the neck kind of behind the ear slightly, and then the skin is redraped over the deeper tissue fixation. The skin is not used as a fulcrum to raise the face, because if you do so, you end up with these kind of vertical lines that look very unnatural and pulled. So the skin now is just kind of laid down in a kind of an oblique direction over the deeper layers and trimmed around the ear in a very meticulous way to hide the incisions and camouflage the incisions. And these incisions heal very, very well over time. Generally, you don't see any stigmata of surgery. However, if the skin is tightened too firmly, if there's too much tension placed on the skin, then you can end up with scars that are unsightly around your ear. And I have a video that's pointed out these complications. Postoperative care is about keeping your swelling down, preventing secondary side effects like hematoma formation and pain relief or discomfort relief. We try to get ahead of the curve in terms of managing each one of these problems. So for instance, if someone gets a hematoma, we now use what's called a hemostatic net on the neck, which is kind of a woven suture net, so that it prevents blood from accumulating in your neck and causing a hematoma, which can compromise the blood supply to the skin. In terms of pain management, I use long-acting analgesics, and by injecting these analgesics into the area of surgery, we get prolonged pain-free periods, so that is not usually an issue. In terms of swelling, we recommend that the patient use ice packs or devices that deliver ice water in a flowing manner to the skin to prevent swelling, and by decreasing the swelling, it actually accelerates the healing process as well. I do use drains frequently to drain away any blood-tinged fluid or other serum that may accumulate under the skin, and those drains may stay in anywhere from 48 to 72 hours, sometimes a little longer depending on how much drainage we see on follow-up care. Some of the sutures are taken out within 24 hours, some are left in for 5 to 7 days, and if you have any staples, we also leave them in for a period of a week to 10 days after surgery. I typically like to have the patient go home with a visiting nurse either for 24 to 48 hours to make sure that they're comfortable, they're safe, and someone is observing their post-operative course. I hope you enjoyed this video, and if you have any further questions, please leave them below. I'm more than happy to answer your questions, and I look forward to seeing you in my next video.